Alrighty, and so introducing our next guest speaker, Dr. Tartaglia is a professor at the University of Toronto and a cognitive-based neurologist at the University Health Network Memory Clinic, where she sees patients with neurodegenerative diseases with a focus on understanding the role of co-pathology across neurodegenerative diseases, including frontotemporal lobar degeneration and chronic traumatic encephalopathy. Dr. Tartaglia employs a multimodal approach, integrating imaging and biofluid biomarker with genetics and clinical data to improve diagnosis and understand the underlying causes of cognitive, behavioral, and motor impairments. Her research aims to develop biomarkers for advancing precision medicine and enabling targeted early interventions. She holds the Marion and Gerald Soloway Chair in Brain Injury and Concussion Research and is the medical lead of the TWH Clinical Research Unit. She is the executive director of the Toronto Dementia Research Alliance. We will have a little bit of time towards the very end of the presentation for any questions. Please make sure you're putting it in the chat. And if you are coming off the break, please make sure that your microphones are muted. So, with that being said, Dr. Tartaglia, you are free to go ahead.
Thank you, and thank you for your introduction. I will share my slides and hopefully everybody can see that. I'm going to assume that's okay.
You are good.
Um, Great, thank you. All right, so I'm going to talk about today diseases that, are actually not as uncommon as all that, but unfortunately are less recognized. So let me just move forward. We're going to cover what are neurodegenerative diseases and, some other common causes of dementia. So I think it's important to remember that neurodegenerative diseases, this is a big family of diseases. And basically, they're conditions in which the brain cells slowly stop working and die over time. And that leads to problems like memory problems, thinking problems. It can lead to changes in your movement as well as behavior. The common examples are Alzheimer's disease, Parkinson's disease, ALS or Lou Gehrig's disease, Huntington's disease. These are the most common ones, but actually they're actually a big family. And when we talk about dementia, it's important to recognize that dementia is a group of things happening, but it actually doesn't tell you very much about what the cause of the dementia is. So dementia just means that you have some cognitive and behavioral symptoms that are significant enough to interfere with your work or your usual social activities. They represent a decline from previous level of functioning. They can't be explained by a delirium, some like slow, some short-lived change or a major psychiatric disorder. And we have to be able to detect the cognitive impairment. And this cognitive impairment usually affects at least two areas. So it could be like difficulty with remembering or learning information, or maybe trouble reasoning or handling complex tasks. It could be, changes in your ability to navigate or to, speak or understand, or it could be changes in your personality. But actually, it's not a diagnosis per se. It's more a reflection of a person's level of impairment. How severe are their problems? It's really an umbrella term that includes many different causes. I already told you about like the ones on the left. Most of these are considered neurodegenerative diseases. So these are the things, that kill your cells one by one. But there are other things that cause dementia. Could be vascular disease, so like from strokes, could be Creutzfeldt-Jakob disease, this is mad cow disease, could be this entity normal pressure hydrocephalus, and other things like multiple sclerosis and brain trauma and infection and metabolic disorders, autoimmune disorders. So all that to say that when we say dementia, actually it's talking about somebody's level of functioning, but actually not telling us anything about the diagnosis. And that is a problem because what's happened is that people have equated Alzheimer's disease and dementia. And so when people talk about dementia, sometimes they're referring to Alzheimer's disease. And sometimes when they say Alzheimer's disease, they're talking about dementia. But actually, that's not all Alzheimer's is dementia, because you could have a very mild form or you could actually have no symptoms at all. Because unfortunately, the word Alzheimer's disease refers to the pathology as well as the dementia or the disease. And the reason that's important is because if you look, this is like from a brain bank. So, these are all these people who've donated their brains when they die. And we look at, how much Alzheimer's disease versus other things is that there is a lot of Alzheimer's, right? You see there 40% there's Alzheimer's, but there's also lots of other stuff, right? There's people who have the Lewy body diseases or frontotemporal dementias or other things. And so, of course, when you're thinking of treating something, you have to think, well, I got to figure out what's going on. And that means you have to know the diagnosis. And these are the different, what we call them proteinopathies. So this purple one here, those are the pathologies of Alzheimer's, but you can see there's all this other stuff too. And so, it's important that you be able to differentiate that. And another concept that I think is really important is that when we think of a disease, you think, oh, the day you woke up with that symptom is when the disease starts. But actually, that isn't correct. In neurodegenerative diseases, the diseases start 20 to 30 years before you end up with dementia, actually, even longer than that. And so, sometimes people think, they have a problem and then they're told they're this is just aging. Well, there is a big difference between normal aging and dementia. And when you have dementia, usually it's because you have a disease in the brain. And this disease started decades before you showed any signs. And so we call that the preclinical state. Then we get into a subjective state. A person notices. Then we get into a mild cognitive impairment, not demented, but they have some cognitive impairment, and eventually dementia. So this could take 20, 30 years, even longer than that. Because, it's important to remember, and, you think this is a very simple concept, but, oftentimes, people start their disease at a very, very mild stage, right? So there's something called mild cognitive impairment where people have concerns that something has changed. They say, I'm not like I used to be 20, 30 years ago. And it is a change that we can detect. So when we give people tests, we can say, yes, you are scoring below what you should for your age and for your education. But the person is still independent. They are not demented. They're able to enjoy their life. They're able to, contribute. Some people are even still working. They're, enjoying their hobbies. They're participating in activities. They are not demented. And I'm just going to start by talking about Alzheimer's a little bit, just because even when we talk about it's not all Alzheimer's or atypical, is that actually Alzheimer's also presents in atypical forms. So, when we think of Alzheimer's, oftentimes people think of this memory problem, but there are many different ways that Alzheimer's presents. It can present as a language problem, a visual spatial problem, a behavioral or executive problem, or a motor cognitive problem. And so even Alzheimer's can present in atypical ways. So Alzheimer's disease, when we talk about this, we're really talking about the pathology of Alzheimer's. So that's amyloid plaques and neurofibrillary tangles made of tau. It's important because it's like the concept of cancer. When we talk about cancers, we talk about specific types of cancer. So if you have a lung cancer due to, some specific types of cells that are different, of course, you would understand that you would need a different therapy than if it was a colon cancer with a different type of cell type that needs to be, targeted. So it's the same thing. This is the disease of Alzheimer's. And this is what I was talking about, is that the Alzheimer's is building up decades before you actually get demented. And so there's a lot of good living that happens for decades before a person has that advanced stage of dementia, which is, what people often think about when they think of Alzheimer's or they think of dementia. So the language variant, well, it's just like the name says. It's a language variant of Alzheimer's disease. So these people, they can have a good memory, they can navigate, but they have difficulty remembering words. And so it's called logopenic variant, primary progressive aphasia, due to the Alzheimer's disease. But you know, completely different presentation, let's say, than somebody. And the pathology is in one part of the brain. It's in the language network of the brain. Another one is called posterior cortical atrophy. Again, Alzheimer's pathology, but located at the back of the brain. And so these people will have difficulty reading. They have difficulty judging distances. They can't tell if things are moving or stationary. They can't, sometimes see objects that are right in front of them. They can have trouble with math, but their memory is just fine. Another concept that, also I would say fits into this young onset, this atypical is the young onset. It's this idea that Alzheimer's disease is just a disease of older people, but it's not. There's many people in the world, when you think of 10% of 55 million people, that's, 5 million people who have Alzheimer's disease and they're less than 65. So in my clinic, I have many people who are in their 40s, 50s, 60s. They don't have any genetic cause, but they have an Alzheimer's disease. So getting back to, this idea of the different pathologies, let's talk about a different group. So Lewy body dementias are people who have cognitive impairment, and they also can have other symptoms. So the most common one is that we think about is dementia with Lewy bodies. This is a different pathology than Alzheimer's. These people can present with fluctuation of their symptoms. They have cognitive impairment, but they also have visual hallucinations, and some of them will also have Parkinsonism, which is that slowness or tremor. The pathology is quite different than Alzheimer's disease, and so we need, a different therapy. And the other side of the coin is people who develop Parkinson's disease, but over time they develop cognitive impairment, and eventually, so they'll start off with Parkinson's disease with mild cognitive impairment, but eventually they'll have Parkinson's disease with dementia. We do have actually tests now that are, being developed and will hopefully be in the, general population, like clinical population, in the next few years, so that we would be able to tell people, yes, you have alpha-synuclein, you have Parkinson's disease or Lewy body disease. Another group of diseases are frontotemporal dementias. These are less common and quite an interesting group. They are actually a family of diseases. There are 6 diseases that fall under this category of frontotemporal lobar degeneration. They're very varied. Some of them are just behavioral. Some of them are just language. Some of them have motor and cognition. And the pathologies are all different. We can have these fused in sarcoma pathologies, TDP43 pathologies, tau pathologies, and sometimes Alzheimer's disease can also present like one of these syndromes. So you could imagine that, it isn't so easy to make these diagnoses. We sometimes have to wait till people actually get into a more advanced stage. We have to look at their imaging. And, but the clinical criteria, can give us good clues. So these are, as a family, they're usually diseases that are fairly common young onset dementias. There's data to show that actually in the young people, like less than 60, they are even more common than Alzheimer's disease. And when you take this whole family of 6 different diseases together, they're actually not as infrequent as all that. It's just that when we compare them to Alzheimer's disease or Parkinson's disease, then of course they would be considered rare, but they're actually relatively they're not that infrequent, let's say. So this is a family of syndromes, and like I already mentioned, the original family had a behavioral variant, and what you see within the blue circle is the part of the brain that is most affected. So in a behavioral variant, you have actually a lot of frontal lobe atrophy because that's where your personality lives. In people who have the language variants, a lot of their shrinkage of the brain is actually in the left hemisphere because your left hemisphere is your language hemisphere. These syndromes are actually quite different one from the other. When you have semantic variant, you can talk a lot, but you can't understand what's being said. If you have a non-fluent variant, you understand very well, but you can't produce words. And all of that to say, well, there's certain parts of your brain that are responsible for those actions, and that's where the brunt of the injury really is. And as I had mentioned, these three members of this family actually ended up in a having a lot more siblings, let's say. And so now we know that this family of three is actually a family of six. And so behavioral variant, what do we expect to see? We expect to see a lot of changes in personality. People who are talking to strangers, they could be walking naked, they could be blurting out offensive statements. Sometimes people become quite what we call apathetic, giving up hobbies, don't really care about being with their families anymore. They're less empathetic. They can sometimes develop what we call ritualistic behavior. They can pick at their skin or pace. They can change what they like to eat. And when we look at their what we call a neuropsychological profile, it isn't a memory problem that we usually see in these people. It's usually what we call executive. So they have trouble making decisions and problem solving. And like I mentioned, all that because of the part of the brain that is affected most. So that frontal lobe that is important for planning and organizing and judgment and inhibition. That's where a lot of their pathology is. And so this is just to show you, the brain, the front part of the brain that is very shrunken, whereas the back of the brain actually looks pretty good. Sometimes people with frontotemporal dementia actually develop ALS. Now, if you know anything about ALS, you know it's a motor disease. A lot of these people will develop, difficulty with walking and moving and even swallowing and breathing. The the issue is that when you look in people who have ALS, some of them actually also have FTD. So it's, one part of the like disease in one part of the brain actually doesn't protect you against disease in other parts of the brain. It isn't even that long that people started to recognize this could happen. So of course, when people have frontotemporal dementia with motor neuron disease or ALS, that can obviously have an effect because that disease, people usually live only 2 to 3 years. The primary progressive aphasias are language disorders. There's three of them. Two are caused by frontotemporal lobar degeneration, and one of them I already talked to you about, and that's the one that's caused by Alzheimer's disease. And these are diseases where you have for the first 2 years, you have primarily language disorders. So you can do everything else okay. A lot of times these people have pretty good memories. They can navigate, they can, still do their taxes, but they have trouble with language. In the semantic variant, basically these people have trouble with understanding words. They can't come up with names. They can't, some of them will have trouble reading if you don't know that the word is pint, then when you would see it, you would just say pint. And so they'll have trouble with reading words that are irregular. And the reason, because of where their disease is. So that's the left hemisphere, and there's much less brain there than on the right side. And here you can just see where their disease is. The non-fluent variant is the exact opposite. These people, they can understand what you say, but they can't get the word out. Their grammar is very poor. They'll try to say catastrophe, and it'll come out as catas one time or catas, and they can't finish it. So it's very frustrating because they know exactly what they want to say. They understand what they want to say, but they can't. It's like their mouths don't work properly to get the words out. And again, the reason they have that is because of where the pathology is. Corticobasal syndrome, as I mentioned, this is a disease where there's like cognitive issues and there's basal, and we call them and motor issues due to where the disease is, like both in the cortex as well as the basal ganglia. So these people will have trouble with, sometimes speaking, sometimes memory, but also they'll have trouble with simple things like they won't be able to dress themselves. They don't have any paralysis, but they can't put the program together to actually be able to zip up, something or to put on their pants. Those actions all look pretty easy, but when you have this disease, they become actually quite complicated. And the pathology, again, very varied. And so this is why as we move forward in our world, we're moving more towards trying to be able to detect what the underlying cause is, because obviously that would have an impact on how you would be able to treat a person with this condition. Progressive supranuclear palsy, another member of this family. This disease was actually discovered in Toronto about 62 years ago. And it used to be called Steele-Richardson-Olszewski. Now it's usually called Richardson disease. These people will have trouble with walking, they'll fall, they have trouble moving their eyes, and they have trouble with Parkinsonism, so some slowness. Their cognitive issues is not so much memory. It is more of like the judgment, the concentration, the registration. They don't respond to the same medication as Parkinson's disease, although they sometimes look like they have Parkinson's disease, but their life expectancy is also much shorter than Parkinson's. And sometimes we get help when we do imaging because we see this funny sign that's called the hummingbird sign, but sometimes their imaging doesn't help us. What about a non-neurodegenerative disease? I already mentioned that some diseases can cause dementia, but they actually are not due to neurodegeneration. One of them used to be called multi-infarct dementia. It's actually a vascular disease dementia. So this is, where somebody will have, some cognitive problems. They may have memory, they may have thinking problems or speaking problems, but it's not due to a degenerative process. It's more due to cerebrovascular disease. So everybody understands cardiovascular disease. If you have a heart attack or you have some damage in the blood vessels of your heart, you can sometimes get angina, but the same kind of thing can happen in your brain. And in your brain, what will happen is that you'll develop what we call the cerebrovascular disease. So that's these white fluffy things that we see. None of that should be there. This is due to high blood pressure or cholesterol or diabetes or sedentary lifestyle, smoking, drinking. And basically, you don't get a stroke, but you get damage to the millions of blood vessels, little by little, one by one, but eventually that will cause a lot of damage to your brain. And so people do, you know, start to have a lot of, memory problems and thinking problems, but they've never had a stroke, and we don't find any Alzheimer's or other pathology in the brain. So this is actually a preventable disease. And unfortunately, sometimes Alzheimer's can live alone, and sometimes vascular disease can live alone. But a lot of times they can live together. And there's some research showing that if you have a lot of vascular disease in the brain, you actually are more likely to have Alzheimer's disease because this disease, can stick better to the brain. So this is very important. It's very important to control our vascular risk factors. This is a new disease that actually only got recognized in the last decade. It's called limbic predominant age-related TDP-43 encephalopathy. It's a lot of words there. So we simplify it, we call it late. These people, they look like they have Alzheimer's disease because their big problem is with memory. They can also have it along with Alzheimer's disease. It's very common, especially in people who are over the age of 85, but it can also happen in people who are younger than that. And this is hard to differentiate just by listening to people's story. You have to actually do some diagnostics, not because we have a diagnostic test for late, but we have one for Alzheimer's disease, so we can, differentiate. If somebody looks like they have Alzheimer's, but they don't have Alzheimer's disease on the diagnosis, on the diagnostics, then we say, oh, they have late. And, it's a slowly progressive short-term memory problem where, they look a lot like Alzheimer's, like I've said, maybe slight differences in the profile, but, you can't use just the clinical profile to tell the difference. And it is a slower progressing. It seems to be less aggressive, and it usually affects older people. And when we look at the pathology, it's completely different. It doesn't look like Alzheimer's disease at all. It's a TDP-43. So again, with the cancer analogy is that obviously you need to know what the disease is because that's how you would target target the right treatment for the right person. So this is just different people who, 97-year-old, when they died, we looked at their brain, didn't find very much Alzheimer's disease, found a lot of late. But while they were alive, all we could say was, their amyloid scan was negative. So of course we would have to say, well, they don't have really Alzheimer's disease. And just to, the syndrome, like I've said, is similar. It only got recognized in the last few years. And so, a lot of times people have been given a diagnosis of Alzheimer's disease, but they actually don't have that. Same kind of thing. Normal pressure hydrocephalus, again, this was one of the diseases on the right. This isn't considered a neurodegenerative disease. It's a disease where people will have cognitive impairment, they'll have urinary incontinence, and they'll have gait changes. They have what we call a magnetic gait. And when we do imaging, we see that their ventricles are very large. The reason this is important to recognize is because actually this is a reversible disease. People who we call it shunting. We would put a shunt in their brain and we would take some of this fluid out and it would really help their walking quite a bit. It has less of an effect on the cognitive issues. It can help their urinary incontinence, but their walking can get much, much better. And so, when we're thinking about, these neurodegenerative diseases, or, actually even before we know it's a neurodegenerative diseases, when we think about the people who come to see us, we're always trying to figure out what the cause of their problem is. So we take a good history. We actually ask informants, so somebody who knows them as well as their own, the person's complaints. We ask them what their chief complaint is, because obviously that gets us thinking, well, what part of the brain is affected, right? And then, how long they've had it, because even like I've said, some of the diseases are a bit faster, some of them are a little bit slower. And so that helps us, and gives us some clues as to what's going on. But at the end of the day, we actually do need biological markers or imaging to help us differentiate the diseases, especially when they're the less common ones. And so this is just to tell us, different parts of the brain do different things. And so, of course, when we're thinking about neurodegenerative diseases, especially the atypical ones that affect, maybe the more the back of the brain or only affect the left hemisphere, like the language hemisphere of the brain, we have to think about what is being affected and what pathology is most likely to affect that area. And then we do, some common tests like a mini mental or a MoCA. The biological markers, these are what we use to be able to test for these different proteins. We can do lumbar punctures for cerebral spinal fluid to measure various proteins. We can do PET scans, blood tests, and skin biopsy. And all that is, very important now because we know that Alzheimer's disease doesn't cause everything, and there's lots of other causes of neurodegenerative diseases, and we do need some diagnosis to be able to, pick them out. One thing that I, always like to remind people, because, for a long time, people really focused on, one pathology. This is the cause of your symptoms, but actually that isn't the reality. And that is going to have, that has significant implications for treating people, right? Uh, the the concept of what we call copathology, having more than one pathology in the brain, is actually a very important concept. And so, this was a large study of 1,800 autopsied adults. And what they saw was that although half of them had 10 combinations, which were the most common, and there was lots of stuff going on, lots of different pathologies, but there was 10 of them that were the most common. But in the rest of the cases, so the 900 other cases, there was over 150 different combinations. And so you could imagine that as we move towards getting treatments, we have now One Health Canada approved treatment for Alzheimer's disease that works at slowing down the disease. It can slow down the disease by 1 year over 4 years of treatment. But when you think about the fact that there's so many different diseases going on at the same time in the brain, you could imagine that in the, not too distant future, we're going to have probably, cocktails that we give to people, just like they do for cancer, where we are targeting different pathologies at the same time so that we could really, slow down or even stop the diseases from progressing. So to summarize, neurodegenerative diseases are a large family of progressive diseases that are associated with different types of symptoms. When we talk about atypical dementias, well, actually, that is a very large group, and so and even Alzheimer's disease can present in atypical ways. So it's really actually, that these atypical causes, become very common and need to be thought of. But when you think of the number of people of Alzheimer's and Parkinson's, the two most common neurodegenerative diseases, since it's like millions and millions of people, of course, everything else kind of pales in comparison, but not compared to other diseases. And that symptoms are good for providing clues to underlying neuropathology, but biomarkers are actually required for accurate diagnosis. And so I think, we are slowly but surely moving out of the time where we use only the clinical symptoms to make a diagnosis. The more biomarkers we use, the more often we realize how we have, not made the right diagnosis. Even in specialized clinics, when we test everybody, we notice that, we get like 20%, 20 to 30% where we tell them they have Alzheimer's and they don't have it, and 20% where we tell them they didn't have it and they do have it. And so obviously that isn't really adequate. And of course, when you think about treatment, it's kind of obvious that an accurate diagnosis is absolutely required for treatment. And thank you for listening. And I guess I'll stop sharing and take any questions that you may have.
Perfect. Thank you. Another wonderful presentation that we have for today. So we have a couple of questions in the chat. The first one is, can you have Lewy body dementia and frontotemporal dementia together?
Yes, I mean, so usually one of them would be the clinical syndrome that a person has. So, Lewy body dementia, we have, the symptoms, like we have the cognitive impairment, we would have the hallucinations, we would have the maybe the fluctuations and the Parkinsonism. Frontotemporal dementia, well, we'd have to know which one they have. So it would be a bit unusual for somebody to have behavioral variant frontotemporal dementia and Lewy body dementia at the same time. So it really depends on which ones because there's so many of the frontotemporal. Sometimes, Parkinson's, like the Lewy body disease, Parkinsonism can overlap with progressive supranuclear palsy or cortical basal syndrome. And so, sometimes these things get mentioned together. And that's why I think it's becoming ever more important to have diagnostic markers so that we can be more precise. Because the pathologies can live together, but the clinical syndromes rarely we would give somebody both of these diagnoses. But it probably can happen.
Perfect. All right. We're going to jump to our next question here. It says, how can you differentiate between Lewy body dementia and frontotemporal dementia since they are overlapping? My uncle has Lewy body dementia, and now the symptoms you are explaining for frontotemporal dementia applies to him too.
Yeah, and that's why we need diagnostic markers because depending on which brain area is affected by a certain pathology, that will give you the symptoms. So sometimes people with Lewy body dementias will have changes in their personality. They can have, some, changes in their eating habits. But when we look at the brains, usually people who have a Lewy body dementia, the brain does not look like the brain of a behavioral variant frontotemporal dementia. In cortical basal syndrome, there are certain changes that we see in the brains. Again, they don't usually look like Lewy body dementia. But I would say that the most important test for Lewy body dementia is that now we can measure in the cerebrospinal fluid and in the skin, we can look for alpha-synuclein. And alpha-synuclein is the pathology of Lewy body dementia. And so those tests are available now in labs. We do them in research, but it won't be that long before these tests are actually made available to people. And so that we aren't saying, well, yes, you have symptoms that overlap two diseases. So maybe there's a little bit of both. That's probably unlikely.
All right, thank you. We're moving on to the next one. It says, is it possible now to see Alzheimer's protein under imaging?
Well, yes, that has actually been around for many years. So with positron emission tomography, so a PET scan, you can't do it with MRI, but with a PET scan, which is an imaging modality, you can detect amyloid, you can detect tau, you can, you know, basically detect Alzheimer's disease.
Thank you. So I'm going to give a second in case there's any more questions down the chat. We just also have a couple of thoughts that kind of came through during the presentation. So it says, very interesting to hear about these different types of dementia. From this person's experience, they say many doctors say the family doesn't matter what type of dementia, they all treat dementia as Alzheimer's disease. I'm not sure my thoughts on that, Dr. Tartaglia.
Yeah, I think that's terrible. Honestly, I think that's terrible. Nobody would go around saying, well, don't worry about which type of cancer you have. It's all cancer anyways. So it should become unacceptable for people to be saying that. I know it still happens. It happens a lot. I also get people who have clearly signs of neurodegenerative disease, and basically they've been told that they're just normal aging. So people are going to have to demand for more and better. Yeah.
Perfect. We have one more thought, one more question. So, I guess a thought and a question one. Why is dementia mostly treated by psychiatrists and not neurologists? Neurologist who saved my uncle, a psychiatrist was treating him as Alzheimer's and it made his symptoms worse. The same scenario repeated with every psychiatrist. I don't understand why neurologists are not the first contact when it comes to dementia. I wish more doctors are all using the biomarkers than just using symptoms.
Yeah, I agree. So one of the issues is the the only neurologists who really do dementia and neurodegenerative disease are cognitive neurologists. I think there's like 15 of us in the province. So you probably want other people to help with seeing patients. I think there's some geriatricians, geriatric psychiatrists. This is an evolving field. It used to be that, people were misdiagnosed, they was thought that some of this was just all psychiatric, right? And so as we learn more, we do better. And but I think it's people having like advocating for better that is really going to change you know, the face of the landscape of this disease, actually, of these diseases.
All right, looks like our last question is how does hereditary work into it?
Yeah, so I didn't get into that because that's a whole other area. But so when we think of Alzheimer's disease, there's two things to think about in terms of heredity. One is a mutation. So mutation means you got the bad gene. If you got the bad gene, unfortunately, you're likely to pass it on, or if your parents had it, you have a chance of getting it, right? And depending on what type of gene, it's either 50-50 or 25% chance. And then there are risk genes. So in Alzheimer's, we have risk genes, and that just means your risk is higher, does not mean you will get the disease, though. So ApoE4 is a risk gene. In frontotemporal dementia, actually, genetics plays a very significant role because there's 20 to 30% of people who have frontotemporal lobar degeneration or frontotemporal dementia that actually have a genetic mutation. So there's 40% who are familial. That means people who have family members with either FTD or ALS in the family. So the different diseases actually have a different genetic component to them. And I would say that in FTD, it's much more of a significant concern than in Alzheimer's disease.
All right, perfect. Oh, there's one more. Is there a way to follow your work or contact you?
Yeah, I mean, if you look up my name, I'm on the internet very easily. I have a lab, my email. I think I put it in the last slide. Maybe I forgot this time, but usually it's just carmela.tartaglia@uhn.ca.
Perfect. All right. Well, one more huge thank you once again on a really amazing topic. A lot of individuals, definitely us society. It's great trying to expand that understanding of, again, dementia's not just Alzheimer's disease. It's that huge umbrella that you showed at the very beginning.